Bismillahirrahmanirrahim. I'm Dr. Talha Zahid. I'm working as Senior Registrar Medicine at Medical Unit 4. Today, the topic of lectures is divided into three categories. Uh, it is autoimmune thyroid disease, the second one is thyroiditis, and the third one is endemic goiter. So, this first of all, there is a brief anatomy of the thyroid gland. As we all know, the thyroid gland is situated in front of the trachea. It is present between the suprasternal notch and the cricoid cartilage, and it weighs about 15 to 20 grams and is about one of the largest endocrine glands in the body. And four parathyroid glands are attached on the posterior surface of the thyroid gland at its corners. The thyroid gland is made of two lobes. It is two lateral lobes which are connected with the help of the isthmus. So the isthmus usually overlies the second to fourth tracheal cartilage. And the hormones which are secreted by the thyroid gland, they are thyroxine, triiodothyronine, and the calcitonin, which is secreted by the parafollicular cells of the thyroid. So these are the three hormones which are released from the thyroid gland. So regarding about the autoimmune thyroid disease, it is divided into autoimmune thyroiditis, which is Hashimoto thyroiditis, and the Graves disease. The Graves disease will be discussed in the other lecture. So while talking about the autoimmune thyroid disease, the thyroid and thyroiditis, so what does the thyroiditis means? It is the inflammation of the thyroid gland. About the causes or its classification, some authorities said this could be the acute, subacute, and chronic form. Regarding acute and subacute category, there is a Hashimoto thyroiditis, drug-induced decurvence, which is due to viral infection, and this the chronic one, which includes Reader's thyroiditis. So the causes, the other classification includes Hashimoto's, radiation-induced, drug-induced, subacute, and acute infectious thyroiditis. So we will discuss these diseases briefly one by one. So first of all, about the Hashimoto's thyroid. It is the most common thyroid abnormality in the United States, and it is the autoimmune disease. What happens? There is a development of the autoantibodies, particularly the anti-thyroglobulin and thyroperoxidase antibodies, and there is the infiltration of cells, the lymphocyte cells into the thyroid gland, which result in destruction of the thyroid tissue, and as a result the thyroid glands become atrophic and fibrosis, and the fibrosis develops and it results in destruction of the thyroid gland. So why it is known as Hashimoto thyroiditis? It was this phenomena was first uh, explored by a Japanese scientist whose name was Hashimoto, and on behalf of that scientist Hashimoto, who reported, he was a pathologist, that this Hashimoto, this there is a thyroiditis which is associated, which develops due to infiltration of lymphocytes into the thyroid gland, and on that behalf, this is termed as Hashimoto's thyroiditis. So it is there is gradual thyroid failure because of autoimmune disorder. So as I have already told, it is the most common thyroid abnormality all over the world and particularly in the United States. It is a disease not only of older women, it can be present at any age in childhood, in adult teen age, and in later age group as well. So although it is more prevalent in older female, but it is not limited to older female, it can present in any age group, particularly in second or the third decade of life. It is concordance rate in monozygotic twins 30 to 60%. So regarding pathogenesis, as I have already told, it is autoimmune disease, and it is due to the development of antibodies and the infiltration of these lymphocyte cells into the thyroid gland. As it is autoimmune disease, but further the Hashimoto's thyroiditis is also associated with congenital disorders like Turner syndrome, and there is also association with the other autoimmune diseases, as Hashimoto's thyroiditis is an autoimmune disease. So the person who is having other autoimmune disease, the disease is more prevalent in a patient who is having other autoimmune diseases, which are like type 1 diabetes mellitus. Brief morphology that of Hashimoto's, it is diffusely enlarged, but sometimes it is but the one lobe may be enlarged more as compared to the other lobe, so it is not always the rule. The capsule is intact, and the gland is well demarcated from the adjacent structures. So this slide is showing but it is the hematoc H&E slide, which is showing the development of the germinal centers, development of the follicles, and the follicles are enlarged. So while talking about the symptoms of Hashimoto's thyroiditis, uh, initially the patient could experience the hyperthyroid symptoms, as there is destruction of the follicles, and there is a release of preformed thyroid hormone, which can result in the hyperthyroid symptoms like irritability, restlessness, agitation. But later, within few weeks, as the gland is destroyed, so the thyroid gland will no longer be able to produce thyroid hormone, and at that stage, the patient would start having symptoms of hypothyroidism, which are including which like low mood, feeling of cold tolerance, and fatigue, drowsiness. The skin becomes dry, coarse, cold skin, and the patient will be having difficulty with learning, puffy face, the weight gain, and in some patients, increased menstrual flow. On examination, there would be coarse, dry skin of the patient, bradycardia, loss of lateral one third of the eyebrow, and delayed delayed phase of or delayed relaxation of the ankle jerk. These all signs and symptoms could be present if the patient is having frank hypothyroidism due to Hashimoto's thyroiditis. Um, while about the diagnosis and treatment, we will discuss at the end regarding the diagnosis, or lab investigation, and the management. So the subacute thyroiditis, it is a self-limited thyroid condition, and it has having again a similar course, trial phase, a clinical course, initially hyperthyroidism, then euthyroid state, and followed by hypothyroidism. So it is responsible for about 15 to 20% patients presenting with thyrotoxicosis, and 10% presenting with hypothyroidism. Subacute thyroiditis, most commonly it is also known as the decurvent thyroiditis, lymphocytic thyroiditis, and it is most commonly due to the viral infections. Most of the time patient is having history of preceding viral upper respiratory tract infection. Certain viruses are involved, like adenovirus, influenza virus, coxsackie virus, and certain other viruses. And because the management is the plan is same in recurrence, therefore it doesn't matter which virus has which virus caused this thyroiditis. So it is known as subacute painful or decurvence, and is caused by the viral infections, which is subtypes of it is lymphocytic thyroiditis, which is the painless. The similar thing, if it is painless, then it is known as lymphocytic thyroiditis or subacute painless thyroiditis. If the patient is experiencing pain, then it is known as subacute painful or decurvence thyroiditis. The third one is postpartum thyroiditis. It is due to after it is present within 1 year of phase. So regarding the subacute thyroiditis, as I have already told, it is possibly due to viral cause. And the clinical features, the patient is having enlarged thyroid gland. Most of the time, patient is having short history of about a few days to weeks. Patient may experience fever, and there is the low to moderate grade fever could be present from days to weeks. Patient will be experiencing pain, and there would be the thyroid gland will be enlarged. It could be diffusely enlarged, and at times the gland will be disproportionate. The enlargement will be disproportionate. It could raise the suspicion of malignancy as well in case of disproportionate enlargement. Uh, but there, when most of the time, there would be history of upper respiratory tract infection. So this lymphocytic thyroiditis, this is the painless thyroiditis, self-limited disease, and presence of there will be anti-thyroid antibodies, and although it is not always the rule that the anti-thyroglobulin and anti-thyroid peroxidase antibodies could be present, but in some cases, about one-third of the cases, the antibodies could be absent. Clinical features are the same as initially hyperthyroidism, and this hyperthyroidism would be followed by hypothyroidism. This postpartum thyroiditis, it occurs in the postpartum phase. Some authorities says it present within 2 to 4 months, but it could be present within the first year of postpartum. Initially, but most of the times, patient presents within 2 to 4 months, and it also involves the three phase. First of all, the overactive phase, which is due to the release of the thyroid hormone, and the patient experiences the symptoms of hyperthyroidism. Then it could there be followed by the euthyroid phase, and after some time, say after many months or after many years of delivery, patient may develop a hypothyroidism as well. So this is the overactive phase, which occurs within first 4 months, and there is a slight enlargement of the thyroid gland, which is associated with anxiety, restlessness, insomnia, weight loss, loose motions, followed by the underactive phase, which lasts for about 3 to 8 months postpartum, and it is characterized by predominance of hypothyroid symptoms, which includes the weight gain, fatigue. And one more thing, this weight, fatigue, and depressive symptoms, which are associated with the hypothyroidism, that these symptoms may persist even once the thyroid hormone is replaced or if the patient is euthyroid. Even then patient complain of this fatigueness and depressive symptoms. So the other one is acute suppurative or infectious thyroiditis. It is rare in immunocompetent persons. Why? Because the thyroid gland is a highly vascular structure. So in immunocompetent patients, there is a very less chance of developing this infectious thyroiditis. It may develop it is associated with the presence, with the persistence of congenital piriform sinus, which cause an access to bacteria and fungi, and even parasites as well. So the causative organism, it could be bacterial, mycobacteria, fungi, and parasites as well. The clinical manifestations include the thyroid gland would enlarge, there would be pain and tenderness, difficulty in swallowing. Patient would be febrile, and that the pain would could be radiating to ears as well. There would be dysphagia, and on lab investigation, patient would be having raised a white blood cell count, which is most of the time present in retrosternal thyroid. That patient on raising the hand above the head, the patient started having facial congestion and difficulty in breathing and engorgement of the neck veins. This is a picture of recursive thyroiditis. This is old age female having asymmetrically enlarged thyroid gland. So while talking about the laboratory findings and Hashimoto's thyroiditis, as it is an autoimmune disease, there is the presence of anti-thyroglobulin and anti-thyroperoxidase antibodies. But in a small amount of patients, these antibodies could be negative as well. So it is not always the rule, but in most of the time, these antibodies are present. So if the patient is in the hypothyroid phase, the TSH would be elevated. So in subacute thyroiditis, which is the decurvence thyroiditis, the ESR is raised. So while distinguishing it from the infectious thyroiditis, in infectious thyroiditis, the TLC and ESR both are raised, while in subacute ESR is raised. Although some authorities says that there could be mild elevation of TLC as well in subacute, but the other signs of acute inflammation will be absent in subacute thyroiditis like tenderness and overlying redness, which is present in infectious thyroiditis. So, what are the imaging techniques which are helpful in the management? Ultrasound would differentiate between the Graves' disease and the development of the colloid cyst or hemorrhage into the cyst or malignancy. So, in case of Hashimoto's thyroiditis, ultrasound has typical features of decreased heterogeneous echoes, and so it is helpful in distinguishing from the other etiologies of goiter. So particularly if ultrasound is combined with color flow Doppler, it further helps in distinguishing the Hashimoto's thyroiditis from the Graves' disease. As Graves' disease, in there would be high blood flow, but in thyroiditis the blood flow would be normal to reduce, but in Graves' disease the blood flow will be increased. So radioactive iodine scan is also helpful in distinguishing the various causes of goiter. In thyroiditis, the iodine uptake scan is reduced, whereas it is increased in case of Graves' disease and in multinodular goiter or in which is in the hypothyroid state. So fluorodeoxyglucose PET scan is useful in thyroiditis. It has typical findings which would favor the thyroiditis. So FNA finding dull aspiration biopsy. It is required if there is a suspicion of any malignancy. There is presence of cold nodules on thyroid scan, and then fine needle aspiration biopsy is mandatory to rule out malignancy. And in case of infectious thyroiditis, FNAC is used to take the fluid or take the for the gram stain and culture uh, to tailor the treatment of the patient. Regarding treatment of autoimmune thyroiditis, if the patient is in hypothyroid state, then levothyroxine about 50 microgram to 150 to 200 microgram per day is required, along with the selenium 200 microgram per day. And for subacute thyroiditis, for decurvence thyroiditis, for the pain and inflammation control, we need NSAIDs like aspirin. For thyrotoxic symptoms like palpitation, irritability, we need propranolol to control the heart rate. Iodinated contrast agents could also be used. And if the pain and inflammation is not controlled and the patient is having significant dysphagia, then glucocorticoids in the form of delta cortical is also used to treat subacute thyroiditis along with the above mentioned things. For infectious thyroiditis, as it is most of the time due to the bacterial infection, so antibiotics is the treatment of choice, and surgical drainage may be required if there is development of the pus, and in rare cases, surgical thyroidectomy may be required. So, in Reader's thyroiditis, there is the treatment is tamoxifen, steroids, rituximab, and if patient is having compressive symptoms, then surgical decompression is required. So it was all about the autoimmune thyroid disease and thyroiditis, and now there is the topic is iodine deficiency disorder and goiter. So the term is used when more than 5% of the population is having the disease. So at that time, the term endemic is used. So this goiter, endemic goiter, is present about, according to WHO, in more than 30 countries all over the world. The countries are deficient. About 30 countries are deficient in daily iodine requirement. So the daily iodine requirement varies from person to person as it is increased in pregnancy, and so the minimum requirement is 50 microgram, and the optimal requirement is 150 to 300 microgram per day. So this endemic goiter is a type of goiter that is associated with dietary iodine deficiency, and at times this dietary iodine deficiency is associated with other deficiencies as well, like selenium, zinc, iron as well. So this slide is showing about the iodine needs, as I have already told, at about 150 to 300 microgram, and in pregnant and lactating females require minimum of 200 microgram per day iodine. And so this is again the repetition that if it is present in more than 5%, endemic is used. This is the peak of endemic goiter. In the pathophysiology, that as we all know that iodine is required uh, for the synthesis of a thyroid hormone. So if it is iodine is not available, then thyroid follicles will continue to synthesize the colloid substance, and the thyroid follicles will continue to increase, which would result in the development of the goiter. The goiter, most of the times, it is asymmetrical in shape, and one lobe is enlarged more than the other. So, but the endemic goiter should be included in the differential diagnosis of any goiter, whether it is multinodular or whether it is endemic. So as I've already told that there is deficiency of iodine and there is no inhibition of TSH, and there is the continuously development and the formation of particles. So what are the risk factors? There are certain areas in Pakistan as well, particularly the hilly areas, which are deficient in iodine. Further, there are certain glycogenous foods which, if patient or if any person takes in large amounts, it can result in the development of endemic goiter, like millet, cabbage, cauliflower, and maize. So these are the goitrogenous substances which can result in the development of endemic goiter. Further, if the patient takes high amount of fortified salt or flour which is having increased amount of iodine, then it may develop it can cause the development of autoimmune thyroiditis as well. So what are the risk factors? Low dietary iodine, iron, selenium deficiency, pregnancy, radiation, increased level of goitrogens, and use of oral contraceptives, use of pickled foods, conservatives. So this thyroid hormone is necessary for the proper development of the fetus, and it may, if it is deficient, the patient could experience miscarriages, abortion, and there is a rate of about 0.5%. Development of cretinism is about 0.5% and per 100 live births in areas where iodine is deficient in the diet. So cretinism is associated with mental deficiency, deafness, squint, and there is permanent decline in the intellectual function, about 10 to 15 points from the baseline. Increased mortality and decreased reduced bone. So this is the peak of cretinism, and we can see this typical hypothyroid look with puffy face. So, what are the signs and symptoms? There is development of goiter, physical development delays, mental development delays. Patient would be having short stature if it develops at the early age, impaired sense of hearing, problem with speech, and so in pregnant females, there is that more chance of developing congenital anomalies. There could be increased incidence of abortions, stillbirth. In adults, there is, as I already told, there is decline in intelligence quotient of about 10 to 15 points. If their goiter is enlarged, there are the compressive symptoms like dysphagia and difficulty in respiration, increased risk of thyroid cancer. Patients may develop hypothyroidism, although some are euthyroid, some may develop hyperthyroidism as well due to autonomous production of hormone. But most of the times in endemic goiter, either patient would be euthyroid or in hypothyroid state. Uh, Diagnosis: patient lives in an area where iodine is deficient, and for measuring low level of urinary iodide, this is the test which is used to measure that the patient is having adequate oral intake of iodine or not. The patient, if the patient is in the euthyroid state, then the TSH would be normal. If in hypothyroid state, the TSH would be increased. And on radioactive iodine scanning, there would be increased uptake. Treatment: if the patient is hypothyroid, then levothyroxine is indicated, and if there is compressive symptoms or for cosmetic reasons, then surgery is indicated. If the prominent nodule, then which are high risk of malignancy, then again the surgery is the treatment of choice. So in euthyroid state, the treatment is the increased intake of iodine, which is in the form of high iodine containing foods, particularly like iodized salts or fortified flour are available. If hypothyroid, then thyroxine. Prevention: iodine fortified food, salt, flour, sugar, water, tea, etc. are available to prevent endemic goiter. Thank you.